Dr. Walks, how?
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to join us. As usual, there's a lot to talk about, and we might as well jump right on in it. I would like to turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone, and welcome to the Black Health Trust. And thank you, Dr. Neighbor Stevens and Dr. Walks, serving as our co-moderators. Right before we get into our first talk of the morning, I just wanted to make a comment. Looking at all of the news that's been going on for the past week or so about the elections coming up and understanding that we don't publicly endorse red, blue, or whatever state is out there. But I believe there's a collective hyper state of mental trauma going on. A lot of paranoia, a lot of just call it craziness of our politicians that are running for office of particularly one particular color, which I'm prohibited from mentioning. And as we go on, I want to find appropriate ways to address some of these issues that I think collectively some of these people are pure crazy. So be careful of who you vote for. Be mindful of who's for things that are of interest to you, your family, and the ones that you love. And with that, it's my pleasure to introduce a person that I've known 1 or 2 years, Dr. Barbara Neighbor Stevens, who is a pediatrician, an executive in managed care, and she is going to enlighten us on issues concerning respiratory syncytial virus. Hello, doctor.
Doctor, with you having said what you just said about what's going on in the news, I feel like before I get into RSV, I want to, for those who are not aware, I want to make you aware that tomorrow is a very significant day in the lives of Black people in this country, as well as for the country as a whole. Tomorrow, the Supreme Court will be again re-examining the issue of affirmative action. They are reviewing cases that have been brought by Harvard University, my alma mater, and University of North Carolina, contesting the basis of the use of race in determining admission. This is a critical decision, and we need to pay attention and act accordingly, depending on how it comes down. All right, Simon, please roll the slides. I'll talk about what I'm supposed to talk about. Now, many of you have not had the opportunity of knowing either Dr. Maxey or myself off the show. And so for those who don't really know, a lot of bantering goes on between Dr. Maxey and myself. And we had quite the banter this week regarding what we should talk about. And he convinced me that we needed to talk about RSV. And so I decided I would try to do this in a way that would unify some of the other stuff we've been talking about and explain what all of the commotion is about in the news regarding the surge in RSV. So I thought I would entitle today's talk, Old Song, New Verse, RSV, or Respiratory Syncytial Virus. Next slide, please. Now, why am I saying it's an old song? Well, for 2.5 years, we've been talking about mRNA viruses, respiratory viruses specifically, And now we're talking about a third one, the RNA virus, respiratory syncytial virus, which is also known to pediatricians as a disease known as bronchiolitis. It is not usually used in the context of adults. You may have noticed in the news for the last 2 weeks, with an increasing crescendo, there has been a lot of discussion about RSV. The reason that there is such a commotion about RSV is not because it's new, not because it's occurring at this time of year, but because of the sheer volume of cases that are coming. And therein lies the problem. Most children, by the time they're 2 years old, before the time of the pandemic, would have had at least one infection with bronchiolitis. And I notice nobody's really talking about this on TV, but quiet as it's kept, one episode with RSV does not mean you are immune for the future. Unfortunately, you can get it more than once. The reason most children have it by the time they're 2 is because this is an extremely contagious virus. I mean, you're talking about drop it like it's hot. I mean, this is one you don't want to come anywhere near. And so when children are attending congregate care, i.e. daycare, they share stuff among themselves. And among the things they share are their germs. And so most children will have had at least one episode of RSV. Usually, RSV is a very mild illness. It is no more than a cold. They and adults, if they get infected, will usually start off with a bit of a runny nose. But in a few minutes, we're going to talk about some of the more severe expressions of the disease. Now, usually we see about 1 to 2% of children under the 6 months of age who acquire RSV requiring hospitalization. And in fact, bronchiolitis and croup, in my opinion, are the banes of pediatricians' existence, because that's what we see mostly in the fall to the spring, and you cannot predict how it's going to go. And so when you have an unknown, at least for me, it makes me a bit more anxious. Now, as of Friday, I saw a report that 9 states were reporting hospitals that were more than 80% full with children infected with RSV. Now, this is what is the big aha going on in the sheer volume of cases. And you might want to know, or you might think, what is causing such a huge number of cases? Well, the problem is, in the next slide, please, Simon. What the problem is that during the pandemic, people weren't having as much contact with each other. So as with influenza, there were really remarkably low levels of incidence of RSV. But now that people are back together, people are not using common sense and wearing masks when they should. And we have a large number of children who have not been in any kind of exposed position because they were in isolation during the pandemic. We have a much larger number of children susceptible to their first case of RSV. And so that's why, or one of the leading theories as to why we're having such a big outbreak. It is not uniform across the United States. However, give it time. If it's not in your community now, it's coming. So who is at risk for RSV? Well, premature infants are at significant risk. Premature infants are babies born before term or 40 weeks. Generally speaking, if they are 35 weeks or less, they are usually given a prophylaxis against RSV. Babies that are born term are susceptible, as are the preemies, but they tend to do better. And I'm gonna get into why they do better in just a minute. Young children who have heart conditions that they were born with, or chronic lung diseases, and children and adults both who have compromised immune systems, and adults in general, and older adults especially, with underlying heart and lung disease. I had I'll never forget, I had a set of twins who were about a year old in the hospital with RSV, and they were in their cribs, and the mama was laid out on the bed that they provide for parents. All three of them were sick as they could be. So it's not to say that you have to have an underlying disease to be real sick with RSV. It's like a bad cold or if you feel like you have the flu, but if you're cultured, it'll turn out to be RSV. Next slide, please. Now, I'm not trying to teach an anatomy course or an immunology course, but I think knowledge is your best weapon. And I wanted you to kind of understand what we're talking about and what it does when we say you've got bronchiolitis. So I want to call your attention to the center cartoon first. I don't know, can you see my pointer? Probably not. Anyway, the cartoon that's labeled A, which is a cartoon of the lung. And then if you look to the your left in the cartoon labeled A, it kind of shows you what the inside grossly of the lung looks like. The lung is like a tree, and it branches into smaller and smaller and smaller segments. And it is the nature of this architecture that makes RSV as difficult to manage as it is. Next slide, please. Now we're going to go a little bit deeper into the lung. If you recall, we had that tree branching into the smaller and smaller sections. At the smallest sections, we have what's called an alveolar sac, or in lay terms, the air sacs. And this is where the work of the lung really takes place. This is where blood is brought into the lung and exposed to oxygen in the capillaries and the walls of the alveolar sacs. And the oxygen is transferred into the blood, and the blood that has had its oxygen replaced with carbon dioxide and other chemicals is removed. So this is where the air exchange, if you will, occurs. It occurs in those alveolar sacs, or those air sacs, and they are the red and pink grape-looking cluster there in the center of the slide. The tube leading to that section of the lung is called the bronchiole, which is just the name of the stem, that tiny stem off of the main airway at the end, or at the top, if you will, of the tree that we were looking at. Next slide, please. Now, I want you to pay attention again to the square labeled C, which again is representing the cartoon of the lung with the tree branches within the lung. And then if you look down at the bottom of that square, to the left, it's showing or attempting to depict a healthy looking air sac. That's the pink one. If you look to the right, you see a pink one that is not as pink as the one on the left. The air sacs are not as big as the sacs to the left, and there are green areas in there, which we're going to talk about in a second, and then there's a gray area. This is a cartoon of what RSV does in the lung. It's the reason I wanted you to understand what RSV does in the lung. It will make total sense why a premature who has an immature and very small airway and a younger child who has a small airway can get in trouble with this disease because they have small airways. Older children and adults who don't have underlying diseases can handle the respiratory virus infection easier because their air sacs don't get as compromised as the individual who has a very small air sac. And indeed, RSV gets into the very small air sac and literally destroys the wall. And once that starts happening, you know, our bodies have that tremendous army of inflammatory fighters. They move in, and that is what's represented by this gray stuff in the air sac. They come in and they fight with the virus, and you have at the end collapse of the air sac and an accumulation of inflammatory debris, cellular debris, and debris from the actual air sac. What that does then, you got this glob, you know, a real scientific term, this glob that then functions as a valve, a ball valve, and it blocks off the air sac. So then the lung is unable to do its primary job, which is to provide oxygen to the blood because the air sacs have now collapsed. So that is, in a nutshell, what happens when you have an RSV infection. And if there are any questions about this, I'll be happy to answer them when we get to question and answer. Next slide, please. This just kind of shows you, again, a close-up of that air sac. And you can see the purple lines are the capillaries bringing the blood to the lung, and the little swirly things are the air sacs where the exchange can occur or doesn't occur if there's destruction due to the RSV virus. Next slide, please. Ooh, something happened with that. You know, it's amazing to me how things get distorted. Could you go back to the previous slide, Simon, and see if it loads? Of course, it was my most important slide. Okay, I wanted to go, let me see if I can show it. Can I share the screen? Okay. All right, can you see my slide?
No.
Not yet.
Has it come yet?
No, it doesn't look like you're sharing your screen yet.
Well, I clicked on it. Wonder what's going on.
There we go.
Okay. So remember I said this was the old song, but we got a new verse, the RSV verse. Well, this is the RSV verse that you can sing along with me. So how do you get RSV? RSV is a virus that is spread through respiratory droplets. That should ring a bell. These droplets, as opposed, it doesn't even get down to the aerosol level that we have talked about. We're just talking about the droplet stage. And these droplets are spread when you cough, you sneeze, when you touch a contaminated surface, or you are in direct contact of someone who is infected with RSV, such as kissing an infected kid. Now, once you have somehow or another gotten the droplet on your hand, and then if you touch your eyes, your nose, or your mouth, that gives the RSV access to your body. And generally, there is an onset of symptoms within 4 to 6 days of transmission. And once you have it, you are contagious anywhere from 3 to 8 days. Let me go back and make a comment about the contaminated surfaces. You know, we kind of downplayed the issue of contaminated surfaces, although we talked about it a lot in the early days of COVID. We kind of downplayed it later on because there were people who reported that, you know, there really wasn't that much viability of the COVID virus on surfaces. That is not true of RSV. RSV is documented to live on surfaces as long as 6 hours. So because of the nature of the virus, it is important that we remember that surfaces have to be taken into consideration, especially frequently touched surfaces, as we talked about 2 years ago. So what are the symptoms? Well, the number one symptom of RSV is a runny nose. Now, that is pretty ubiquitous. People with allergies have runny noses. People with sinus issues have runny noses. People with COVID have runny noses. And people with influenza have runny noses. So a runny nose in and of itself does not mean that you definitely have RSV, but at this time of year in a young child, it should be top of mind. There's some others, parainfluenza and a few others that we also have to worry about in children, but runny nose. And in my experience, frequently the kids run low-grade fevers, low-grade meaning that if normal is 98.6, then a low-grade fever is up to 100. But frequently in younger children, you will see temperatures up to 103 and 104. Children don't tell you, especially babies, that I don't feel good, but they, you know, and with words, but they tell you with their actions. They get fussy. They start refusing their bottle, or if they're breastfed, refusing the breast. If they're off the bottle, they don't eat as much. They are laying around. And the same thing for adults. They have a headache because they have a fever. They have a runny nose. They don't have as much of an appetite, and they have what we call malaise in adults. Then the cough starts. And this is when the virus has begun tearing up those air sacs that I spent the last few minutes talking about. And as those air sacs begin to collapse and block off the bronchioles, you start having wheezing. And then depending on the severity of the infection, which will be determined by the size of the child's airways or the condition of the airways in an adult, you may start seeing not only coughing and wheezing, but signs of what we call increased work of breathing. Now, what does that mean? This is something that you can tell very easily in children because they have nice thin chests. Fat old adults, you can't see this. But in children who have no thick fat layers in their chest, when they try to breathe, the air is sucked in between the ribs. So with each breath, you see this sucking in of the rib cage. That's called increased work of breathing. So when they start wheezing, by the time they start wheezing, you need to be in touch with your provider. And if they're having increased work of breathing, you definitely need to be in touch, and you will probably be instructed to come into a facility for treatment. When you, as with COVID and with influenza, once the symptoms begin and you see a worsening in the symptoms, you need to reach out and touch base with your provider. And in the words of Dr. Steiner, have your action plan worked out. So, what treatments are there? Well, unfortunately for RSV, which is why I said earlier, this is a disease that gives me a lot of anxiety. All we can do is what we call comfort and relief of symptoms. So for the fever in general, we recommend acetaminophen, lots of fluids, because they've got a fever. They're producing a lot of fluid in their lungs because of the irritation and inflammation. So they have an increased need for fluids at a time when they have a decreased interest in taking the fluids, which is a recipe for what's called dehydration. So you want to really push the fluids, and you want to monitor that breathing very closely. I urge you, though, especially for children, but also adults as well, but especially for children, please consult your provider before you start at giving them any over-the-counter cold medicines, because some of those medicines can make the situation worse. And again, as I said earlier, if you notice that the child is getting worse, and I'm not talking about waiting 2 days, I'm talking about in a matter of hours. If you see that the child is beginning to get worse, you need to reach out and consult. If things are really bad, if the child is choking and just really not having, is really having a great deal of difficulty breathing, get to the emergency room. Now, if they get to that point, what is it that we do? Well, I'm smiling because I'm thinking about an old-timey remedy that I'm not, and I know this is going on internet and everywhere else. So I am not saying that this is what you should now do. But in the old days, before the time of a lot of medicine and stuff, when children and babies had a lot of congestion in their nose, mamas used to suck their noses out with their mouths because they knew they needed to clear those nasal passages. And so we still need to do the same thing now, except we have technology that can assist us. So we clean out the nose with suctioning. We provide them with oxygen as needed. We give them usually intravenous fluids to keep them hydrated, and medicine to control the fever.
You have a bulb syringe, right?
Once they're in the hospital, no, we usually use wall suction, but at home, you certainly could use a bulb suction. And then if they're really bad, other medications may be added, such as steroids. And then it's a matter of waiting it out. And typically, once they get really bad, they stay bad maybe for a day and they turn the corner. It's amazing. They can be so sick. And then in just a matter of a couple of days, they are almost back to normal, which is a good thing. Now, adults, as I said earlier, this tends to be like a bad cold or the flu. And so the same kind of symptoms and treatments that you would do for that is what is usually given for adults. And I emphasize, it can be a very serious disease in adults who have underlying heart disease and lung disease. Next slide, please. Oh, that's right, I'm in control now. Okay, so this is what I call the respiratory virus chorus. Prevention. What can we do to prevent this? We can do what we've been saying for 2.5 years. You can wash your hands, you can use masks, you can disinfect surfaces, you can use safe distances, and you can isolate if you're having symptoms. And with that, I will close and entertain any questions anybody has.
Thank you very much, Dr. Neighbor. That was wonderful and important. I'm so glad you agreed to do that. So,
I have a question, Dr. Neighbor Stevens.
Yes, Dr.
It
Walks.
seems like so many times something is wrong and we're like, we'll do this and this, and if that doesn't work, we'll do steroids. Can you just, without getting into a whole immunology lecture, can you just say a little bit about what is it that steroids will do for that process you talked about when the immune systems come in? That slide had the gray on it, and it seemed like the immune system just made a mess.
Well, it's not only the immune system, and it's all of the things going on at that point. But what the steroids do is they mitigate or they lessen that inflammatory response and decrease the fluid secretion that accompanies an inflammatory response. So the short version is that it decreases the congestion.
Okay, thank you.
No other
questions? I don't see any questions in the chat, which usually means that you did a great job.
Synergist.
Well, there's a comment in the chat. What is the role now of Synergist? Steroids are not recommended in bronchiolitis. That's from Dr. Bean.
The role of Synergist is still restricted to use in the preemies. It has not been approved for extended use. Although this is just me. I'm thinking that's coming, especially after this experience.
Okay.
But I don't think, if I remember correctly, and Synergist has been around since maybe 1998. I don't know that they went to the FDA for approval for anything other than in preemies.
Okay.
You want to tell us what Synergist is?
It's the name of the drug that I mentioned in the talk that is given to preemies before they're discharged from the nursery if they're less than 35 weeks to help prevent getting the infection. And yes, there has been a lot of back and forth on the whole steroid. And I'm smiling because sometimes there is a delta between what is recommended and what is practiced. There is certainly, there has been a lot of discussion about the role of steroids in bronchiolitis that is caused by RSV. And AAP did come out with, maybe 2 years ago now.
Who's AAP?
The American Academy of Pediatrics, that the use of steroids in bronchiolitis does not improve the outcome at all. But I will tell you, from reviewing charts, it is still used.
And there's a request, Dr. Neighbor Stevens, that you please review the formation of the quote unquote glob formation in the alveoli.
Oh my goodness. We don't want to talk about that. I started to show that cartoon and I said, no, that's not the purpose of this. Okay. But what it, again, at a very high level, when the soldiers come in to fight the war, which is being caused by the invasion of the RSV virus, there is an accumulation of fluid. There is destruction of the alveolar sac walls. There is debris created by that process, which results in the glob.
What came to my mind as you were describing that is like that little black thing that comes down when you flush the toilet. to hold the water in and close it off. That's what that glob is. At least that's my mental picture of it.
Well, actually, it contributes to the problem because the glob then tends to block off the bronchiole. And so you don't have the air exchange and you have collapse of that area. So it's doing its job, but it, like with many things, there are unintended consequences.
Well, thank you so much for an important piece of information for our parents and grandparents.
Dr. Maxey, could I ask if Dr. Bean has any other additional comments since she's on? And Lord knows she's right there in the trenches dealing with it.
Only if you introduce her first.
Oh, introduced Dr. Exelana Bean, who is chair of the Department of Pediatrics at Meharry Medical College, and an old colleague and friend, and who is, as I said, every day in the trenches at Nashville General Hospital, currently now dealing with RSV, but also having had a lot to do with the work Meharry did in the Nashville community with COVID. Dr. Bean.
Thank you very much. And a few things. Synergist worked extremely well. And at one point, you could use it in children up until 35 weeks. But this is one of the few instances, which I never quite understood, in which an actual campaign was raised against the use of Synergist in that population, and successfully, such that it was restricted now to the use of only preemies who were 28 weeks or up to 30 if they were on oxygen. And I'll tell you one of the reasons why we got involved. In this case, an actual campaign sponsored by the pediatric section of the NMA to try to get the American Academy of Pediatrics to rescind that recommendation, or at least acknowledge the fact that there was a disproportionate impact upon minority and poor children from RSV because they had higher risk factors beyond just prematurity, being in crowded residences, had increased incidence of asthma, increased exposure to tobacco, whole bunches of social determinants, which resulted in the fact that they actually had a higher incidence. But we were not successful. I always find it, and the NMA actually wrote sponsored by the pediatric section, actually wrote multiple letters to the AAP and even went to the American Academy of Pediatrics and spoke with them about it. But we were unsuccessful in getting them to liberalize the use of Synergist. It'll be extremely interesting to see what happens, as you pointed out now, where we are seeing now another epidemic of babies and who have RSV and the increased hospitalization. But their justification, which I always find interesting, is that disparities did not come to the level of them deciding to make a decision not to support that. Most of the children, as I said, the criteria beyond 32 weeks up to 35 weeks, that population were based upon risk factors that were primarily seen in poor income children. And they decided that the cost of trying to save hospitalization for those children didn't meet the criteria for them recommending that it be used beyond that age group. And in fact, they ignored entirely all of the data. I still have all of the articles that we used to show that actually that population was disproportionately impacted. But as you know, the concept of disparities and the concept that you should actually take that into account in making public health decisions has become a relatively recent acknowledgement with COVID. So it'll be interesting to see if people begin to look back at that issue and address that particular issue again, because it's a very, very effective drug in terms of preventing it. Thank you.
That sounds like a Supreme Court case, but I would like to publicly invite you to come back as soon as you want to and give us an afternoon update on disparities in pediatric care or any other subject that you deem. So if you contact me and Dr. Neighbor-Stephens on that, we'd love that very much.
And it looks, thank you, Dr. Bean, so much. Dr. Maxey, it looks like Dr. Jordan has a question or a comment.
Dr. Jordan? Can you unmute Dr. Jordan?
I'm unmuted. Can you hear me?
Yes.
Yes, sir.
Hi, Excelana. Question. Why can't the NMA make a strong recommendation itself rather than still playing stepchild to the American Academy of Pediatrics? I mean, if you all have the data and you show that, then why can't you come out and make, I mean, we keep yes-sowing ourselves. Why can't you all come out with a recommendation if you have the data to show that it's affecting your kids? It's because it's your kids that's being affected more than their middle-class kids. That's my question.
Dr. Bean is back on mute, if that was
Yeah.
for her, Dr. Jordan. Oh, there we go. Dr.
You
Bean.
have the same problem. The American Academy of Pediatrics, this drug costs money, okay? And it was relatively expensive. And the data they used was the usual one, the one where they asked how much money does it cost you to treat this number of children versus how much money you save in terms of hospitalizations, et cetera. But specifically, that means the insurance companies were not enthusiastic about paying money for unless they had to. When the American Academy of Pediatrics recommendation came out, the insurance companies jumped on the recommendation and said, well, we don't have to pay for this anymore. And the NMA at that time, and I understand what you're saying, and life has changed somewhat. The reality is that people are listening more to the issue of such as the National Medical Association. And perhaps that they at this point might be a force that might actually bring about some change. But basically, American Academy of Pediatrics made the recommendation. Insurance companies jumped on it and said, we're not going to pay for it. And their justification was, look, American Academy of Pediatrics says we don't have to pay for it. So we went to the American Academy of Pediatrics to try to get them to address this issue. They refused to address the issue. And well, they listened politely, but they did not change their behavior or change their recommendation. It'll be interesting to see what happens this time around in terms of which children get impacted and whether there is the same disparities we saw before.
And we
And
sort of
maybe
had
the outcome
something
could be
similar.
different.
We had something similar with HIV and AZT and early drugs, because those drugs were very, very, very expensive. But we raised hell and said we're not going to have a two-tier system. But I think it's up to us, and the NMA drags its feet a lot when it comes to those things. Still, we need to be more in the forefront and pushing the agenda rather than still waiting for the majority organizations to say, okay, yeah, maybe no, etc. If you have the data to show that this drug can help save some Black and brown kids' lives, then we need to be on the forefront and do it, period. And it is just getting the American Academy, but we can go to TV stations, we can do everything too. I just think it's time for us to wake up and remember the beatings that our parents took to get us into medical schools, etc., and stop acting like we're free when it comes to that. I just don't want to see the Black kids dying because they can't get something that if you used it, it would work. And I think that's very important. We went through hell with HIV in the early days getting drugs. And looking back, I'm very glad we did. And I think now we need to do the same thing with this for kids. If you and other experts in pediatrics who are Black think this is something we need to do, then we need to raise hell to get it done.
Well, I think you're right. and I think that should be one of the subjects in our next advisory meeting that will be coming up in another week. Thank you so much, Dr. Bean and Dr. Jordan. Let's go to our slides if we can, Simon.
Dr. Maxey, while Simon is pulling up the slides, there is there's a comment or a question in the chat about whether the alveolar glob formation is that similar to the immune response. Now, I know that you addressed that, Dr. Nabors-Stevens, but that came in right after you addressed the glob. And I think it goes back to a problem I had in medical school. I didn't understand initially, and I think I understand now, why when our immune system was coming to help us fight whatever was trying to kill us, that we would use anti-inflammatory drugs when the inflammation was part of what the immune system was doing. It didn't make any sense to me. It seemed like our body was doing something good, but we kept trying to stop it from doing something good. And I think that's what this question is asking for some clarity on. Maybe we can do a whole lecture just for me on the immune system and why we keep trying to take anti-inflammatory drugs when our body is creating inflammation trying to help us. So y'all can just get back to me or call me at home and explain it to me, okay?
Dr. Ross, I think that's an extremely good comment that you're making in discussion, and we should go back to some of the principles of what disease is and how inflammation plays a role, sometimes constructive and sometimes not so much. But I think we should do that at some point.
Okay.
But in the meantime, let's go to the slides. I think we have a limited amount of time. So as usual, I'm going to ask Dr. Walks and Dr. Nabors-Stevens to read some of these slides and moderate questions that are listed here.
All right, I'll go ahead and jump in and get started, Dr. Maxey. The title of the slide is What the Future May Hold. And bullet number 1, if vaccination continued at its current pace through the end of March 2023, a potential winter surge in COVID-19 infections could result in a peak of around 16,000 hospitalizations and 1,200 deaths per day by March 2023, researchers said. Going to the second one?
Yes.
Okay, second bullet. About 90,000 lives would be saved and more than 936,000 hospitalizations could be prevented if 80% of Americans eligible for the latest COVID-19 boosters get vaccinated by year's end. And that's according to the Commonwealth Fund and Yale School of Public Health. The third bullet, the big picture, even matching 2020 and 2021 flu vaccine levels of closer to 50 to 55% could save about 75,000 lives and prevent about 745,000 hospitalizations. And why it matters? The US is on track for a far lower rate. Only 36% of adults older than 50 have gotten second boosters.
And that means that in communities of color, that number is even worse. So we're going to be more severely affected by this. And I understand that misinformation is a major part of that reason. What do you think?
Well, my thought about all of this is, although we can provide, and Lord knows, Black Health Trust has been trying to share vetted, credible information for 2.5 years. And we will continue to try to do that. At the end of the day, each of us individually are going to have to do all that we can to protect ourselves, because the country that we live in is on track to not doing what it needs to do. I hate to sound so pessimistic, but I don't really see any alternative other than doing what you can do to protect yourself. But I have to say, what popped in my head when I looked at the initial title of this was something that I saw on CNN, where they showed some scientists in Africa all garbed up in protective gear in some bat cave somewhere in Africa, extracting samples. And what the story was about was looking for the next virus that could lead to another pandemic.
But this is Dr. Jordan. There are things we still can do also. More of us could be on radio programs to talk about this. We could go to community groups. It's great we have this, but I think we have to now, and I underscore the word we have to be the ones to do the next level of doing things to educate our community. And yes, I mean, there's a lot of mixed feelings about this, about COVID, etc. When COVID first started, some of the schools didn't want to do anything. They asked some of the faculty from Drew to come. I went to one school. I spoke to the honors class. The entire class said they were refusing to take the vaccine because they were trying to do a Tuskegee on them. And when I asked them, take out a pencil and a piece of paper, write down what was Tuskegee. Now, one person knew what Tuskegee was. My response was, if you're going to use Tuskegee as an excuse to not do anything, at least get up your lazy bad word and find out what the hell Tuskegee was. Because you just called me the N-word, I don't appreciate that. They didn't understand what I was talking about. But I think we still can do. And we're not going to convince everybody. But I think, we can be more proactive. We can write letters in the Sentinel and the other Black newspapers and other papers. We can speak on some of the radio shows, and not at 5 o'clock in the morning, but some of the shows that I'm doing today. But I think we now have to be a little more proactive and go out to the community and do things.
Dr. Walks, you're our psychiatrist. Why is our country so crazy? You're supposed to cure us.
Dr. Maxey, in all seriousness, this is a very big problem for us as a community and as a country. I go back to maybe 3 weeks ago, we had someone put in the chat that we can't trust anybody, and they had a long list that included doctors and universities and scientists, and it didn't leave anybody off the list that we would call a credible messenger. And it made me sad to read that, because I think it's just emblematic of where a lot of people are in our country. They are so confused. That same week, we had somebody put in that Dr. Fauci was on the Moderna patent, and then somebody else put in there, you just read that on the internet, that's not true. And it's challenging, because we do have folks who are willing to take some information from a stranger on the internet or a celebrity on the internet that is repeating something that they got from a stranger on the internet. And so it's harder for us. But I think Dr. Jordan's point is exactly right. We do have to be willing to go out and sometimes get called the N-word and sometimes have people not listen to us, but we have to make sure that we are consistently giving vetted, credible information that can stand up to scientific scrutiny. And because of our personal credibility, Dr. Hilsrer talked about that when he was on the Black Health Trust a few weeks ago, leveraging his personal credibility, as massive as it is, to get people to believe that he's speaking the truth and speaking in their interest. So Dr. Jordan's on point. We cannot stop, because so many folks that don't have anything useful to say continue to talk all the time. And they are getting up at 5 a.m., Dr. Jordan, and they're staying up. So we cannot get weary in well-doing. we've got to continue with what we're doing.
Very good. Let's go to the next slide.
I think I put Simon to sleep with my little diatribe there. Okay, share of Americans with long COVID who also reported significant activity limitations by race. The data is from a September 2022 survey of 50,258 US adults, non-Hispanic Black Americans, as well as Hispanic or Latino Americans are more than 10 percentage points above the national average of 25%, while non-Hispanic white Americans are 5 percentage points below it. So this again is the share of Americans with long COVID. Non-Hispanic Black, 38%, Hispanic or Latino, 37%, US overall, 25%, non-Hispanic white, 20%.
So again, the disparity is heavily in favor of Blacks having more long COVID. And we know that's a problem, Hispanics. But part of the reason that whites aren't concerned is they don't get the same degree of this, but it affects them as well. And this affects your cognitive ability, your physical ability, early shortness of breath from less exercise, and all those things. And my concern is cognitive ability. That's what I know we should all, that would stop us from being woke. Is that right?
Dr. Maxey, do we
Yes.
have any additional information on why this impacts our populations of color more? Is it less access to treatment? Is it poorer initial health status? Do we know why?
There are several reasons. One is, and I just gathered this yesterday, for people under stress who presumably have higher cortisol levels, it can affect them, that there may also be some genetic predisposition of the way it affects the brain. But the honest answer is I don't know that the jury is totally in. This is what the next slide says on that.
All right, long COVID, the big picture. Long COVID symptoms can include shortness of breath, cognitive difficulties, and symptoms that worsen even with minimal physical or mental effort, a primary indicator of chronic fatigue syndrome. The bottom line, as winter months near, an expected rise in cases coupled with fewer COVID protections could mean millions more will get long COVID, and there's little to no safety net in place to help them.
Is this saying that we should continue the COVID precautions in many neighborhoods, especially the mask and social distancing and hand washing that Dr. Nabor-Stevens mentioned before?
Yes.
Yes, at a minimum. I think there's an economic part of this also, and a larger number of Black and Latino persons are poor and are crowded. You know, I had to make a home visit, but 3 weeks ago, one of my Latino patients, there were 12 people sleeping in one room. Now it looked cute, but I thought I had my own bedroom when I was a kid. I have never in my life had to sleep in a room with 12 people. And I don't want to sound arrogant, but I'm sorry. As cute as it looked, yeah, I realized if one person in here starts coughing, everybody has something. And because they're Latino or Black doesn't mean we know that. I mean, a lot of our friends, family, patients are living in conditions very different than those of us on this call. And if there are, 5 or 6 people in a room and one person has a cough, they all got it. So I think we have to understand there's a whole different level of lifestyle that a lot of poor Black and Latino patients have that thank God we don't have, but that also can be a factor.
In addition to that, another reason why our communities are at increased risk It's because not only do we have the crowded living conditions, but typically we have the jobs that put you in close contact with
Correct.
public
Mhm.
and increases your exposure risk.
Thank you. Let's go to the next slide.
Who is at greatest risk? The people at greatest risk for severe and fatal outcomes are those who haven't yet gotten vaccinated against COVID-19.
What'd you say? I didn't understand that.
The people at greatest risk for severe and fatal outcomes are those who haven't yet gotten vaccinated against COVID-19.
My
If you
goodness.
don't get your shot, Dr. Maxey, you're at greater risk of a severe outcome or a fatal outcome.
Interesting.
Yes.
I'm gonna listen to you on that one.
Dr. Maxey, we know you have pushed over 5 or 6 people to get in line for your COVID shot every time they have one. So we're not worried about you. According to KFF polling, this group that hasn't gotten vaccinated yet, this group has proven very resistant to change, although some are slowly coming around. And the last bullet on this slide, the FDA did not yet authorize the bivalent vaccines for use as a primary series or to boost a previously infected but never vaccinated person. An updated primary series based on the bivalent vaccine might provide better protection. The bivalent vaccine would essentially initiate 2 different primary series responses, one against the ancestral viruses and one against the Omicron subvariants.
Yeah, let me comment on that one. This is saying a couple of things if we unpack it. That even if you've had COVID and not been vaccinated, that immunity from the infection can still be improved by becoming vaccinated. And so a lot of people are using the fact that they've had COVID, tested positive, that they don't need the vaccine. But it's been shown you still need to have the vaccine. That's one. And number 2 is, what is the new vaccine and new boosters consist of? There's the ancestral or original COVID, as well as new variants, and the new vaccines hopefully will emphasize that we need to be protected against all of it. Any other comments on that before we go to the next slide? Let's go to the next slide.
CDC, new approvals. The CDC's Advisory Committee on Immunization Practices, the ACIP, voted unanimously to add COVID-19 vaccination to its panel of routine immunizations for both kids and adults. The 2023 child and adolescent immunization schedule for those age 18 and under will now include Pfizer/BioNTech's COVID-19 vaccine and Moderna's COVID-19 vaccine, Pfizer and Moderna's bivalent vaccines, and Novavax's COVID-19 vaccine.
Let's keep going.
Is there a preferred vaccine? Yes. For primary series vaccination, Moderna, Pfizer-BioNTech, and Novavax vaccines are recommended. For booster vaccinations, and Pfizer-BioNTech are recommended.
Now, a few weeks ago, Dr. Hilton said that his next vaccine is going to be the Novavax. Am I right?
I think he did say that.
Yeah.
So Novavax COVID-19 vaccine for booster vaccination and Janssen COVID-19 vaccine for primary series and booster vaccination should only be used in very limited situations.
Okay, let's keep
Nice if we could add a time limit here, because some people have had these, but they don't know how much time needs to be between vaccinations.
Yeah. Why don't you take the next slide, Dr. Jordan? Sammy, go to the next slide.
Does the 4-day grace period apply to COVID-19 vaccine? Yes. Doses administered up to 4 days before the minimum interval, known as the 4-day grace period, are considered valid. This applies to primary series and booster doses of vaccine. Do not use the grace period to schedule doses. The thing is blocking. If a dose is administered earlier than the grace period, see Appendix D for guidance on corrective actions. It is considered a vaccine administration error. You are required to report COVID-19 vaccine administration errors to the Vaccine Adverse Event Reporting System. Doses administered at any time after the recommended intervals are valid. But I think the issue, because I have patients calling, they've had 1 or 2 of the boosters. Is it time to get something else? When would you have your last booster? 2 months ago. My answer is, then let's wait a while. But let's try to get it before the end of the year, so you can develop some immunity. I mean, that's the problem. And other people, a lot of people don't know what they've had. I got a vaccine. Was it the primary vaccine or was it a booster? I don't know. They just gave me a shot. Who gave you the shot? You got to call to find out. Do you have any kind of card or anything that shows what you have? Some do, some don't. And that's a problem.
So that's something we have to tell people, make sure they get written evidence of what they've been given.
Yes, people should. And some people don't. This is no different than what we did in India and Ethiopia and Nigeria with smallpox. People did the same thing and people wouldn't get. My worst experience was that a family, he had 11 children. He refused to let them get a smallpox vaccination. We go back through the village 6 months later and 9 of the kids are dead.
Mm.
And of course, he's wishing out, crying. I wanted to choke him that we had done it then, but we couldn't. And we've seen cases here where families, in particular the first year, where people wouldn't take it. Some of the families were now taking it because somebody had died or 2 or 3 people have died. But you can't rewrite history when that happens. So I think we have to look at other things. We're not going to save everybody and we're not going to convince everybody, but I think we have to be a little more proactive in trying to get people to get a vaccine. But again, so many Black people don't have a primary care provider. People will show up at the emergency room at Gardena Memorial or Martin Luther King. That is not where you find a primary care provider. And I think one of the things we need to try to encourage people to do is go see some, if you got time to go to a football game, to stand in line to hear Kanye do some of his nonsense, you got time to find a primary care provider. And it's called priorities. And we need to learn how to better organize our priorities. Because I can't get upset with a provider who has never seen you and you come in the last minute wanting something. A lot of people who don't have insurance in this state could have insurance, but people don't think of it as being that important.
Let's go to the next slide, Dr. Walks.
This slide, can we vaccinate patients with underlying medical conditions? The answer is yes. COVID-19 vaccination is recommended for everyone ages 6 months and older, including people with underlying medical conditions. COVID-19 vaccines are especially important for people with underlying medical conditions associated with higher risk for severe COVID-19.
Let's go to the next slide too. Unless you want to comment more on that one.
Unless I want to comment more? No, Dr. Maxey, I think it's important for folks to understand that you can't say, well, I've got diabetes or I've got high blood pressure, and so I shouldn't get a COVID vaccine. That's exactly the opposite.
No.
If you
should
do
get
have
one.
something underlying, all the more reason to protect yourself. Okay, if a patient is sick, can they be vaccinated? Well, the number one, as with other vaccines, you can vaccinate patients with a mild illness. A moderate or severe illness is a precaution to receiving a COVID-19 vaccine. It is not considered a contraindication. Generally, vaccination should be delayed until the acute illness has improved. However, if you and your patient believe the potential benefits of vaccination outweigh the potential risks, they may receive COVID-19 vaccine.
So this is saying that COVID-19 is more dangerous than most other things. So if your physician or provider or whatever you call them believes that you're at higher risk from COVID vaccine than your current illness, by all means, get that vaccination. Is that your understanding, my co-moderators?
Yes.
That is my understanding, Dr. Maxey, and I think it underlines Dr. Jordan's earlier point about how important it is for folks to have a primary care provider so that there is someone you can talk with about your particular situation.
Okay, let's go to the next slide.
I think that's the last slide, is it?
Looks like.
I thought there was one more.
It looks like I'm seeing 23 of 23, Dr. Maxey.
Okay, then that's it. So let's make, I know we're close to the allotted time, but we've got a few more minutes that we should.
Rando,
Yes,
is it possible to invite Dr. Casmia Corbett for one of these sessions, or did I miss it? You know,
No,
she's one of the two women who created,
we've invited her
COVID
many,
vaccine.
many times. She
and
has
she's
not,
Black.
she has not responded. We'll do it again.
Okay, yeah.
So she's now a professor at Harvard. Maybe Dr. Neighbor-Stevens can convince her to come. But we wanted to review a lot of this data on COVID and long COVID, even though we've done it a million times. I want to make sure that people understand that COVID is still out there. But the basic tenets of avoiding COVID, I think, apply to so many other things, not only respiratory syncytial virus, but cleanliness in general is something that can save us from a lot of bad habits that we have developed as Americans, and protecting ourselves from those who don't care about our health and your health. And again, with this time of elections coming up and all these crazy patients of Dr. Walks being out there, especially in red states, we need to try to put people in office that are going to have particular concern for the fact that there are health disparities that affect us more so than others, and all the data is showing that. Are there any questions or comments in the chat, Dr. Neighbor-Stevens, Dr. Walks?
I'm not seeing any.
I just want to say, Dr. Maxey, as we used to say back in the neighborhood, you're going to stop calling my patients crazy, because the overwhelming majority of the patients I see have had their vaccinations and have had their booster shots. And one of the reasons for that is that I let people know that I think it's important that they do that. And so I think that we can continue to let all of our patients know that we think it's important that they talk with their primary care provider and they get their primary series and they get their boosters. And we will reserve the term crazy for the folks who refuse to get a booster and refuse to get a vaccination and refuse to take their flu shot. There's a whole bunch of people put on that list, but that list doesn't include my patients, Dr. Maxey, because I'm a good doctor and they're all better.
Good. But remember, we had one woman on here that one of our doctors didn't believe in vaccination.
Yeah, hold on one second. And Dr. Walk, you didn't understand. I'm giving you credit for being America's psychiatrist.
Dr. Maxey, I'm going to just leave you alone. You go ahead, sir.
Okay, there was a comment, I think, at the end of the last slide. I didn't see it. But one of the considerations with these new vaccines, they're wondering, should you consider adding monkeypox to that schedule and to those multiple vaccines that you could get at once? And that's a question I'm going to ask Dr. Jordan.
Well, that's an interesting question. I attended a group last week of Black gay men. There was 38 of them there. And they were complaining because we'd gotten what's held to offer monkeypox vaccination. But they wouldn't go. They all came, but then none of them would go over and get the shot. The only ones who went over were the gay white kids, because going over, getting a monkeypox vaccine says, I'm gay. And we're still having to deal with the problem of too many young Black men not being comfortable having people in their community knowing that they are same gender loving. Stigma is still a big problem, and that is another issue we need to deal with. If we're going to have people get it, we need to figure out a way where they can go to get it, where they're going to be comfortable and not be profiled because they got it. And I didn't realize that until we had the meeting. They called Better Brothers, but it was just, it was ridiculous. Not one of the Black same gender loving men would go over and get the vaccine because they were afraid somebody would see them standing in line.
All right.
And we had that same problem with HIV in the early days. Remember, we had people would even come and park and hide in the parking lot to see who was coming in the clinic and go out and spread the word. So, I mean, that's another issue we have to deal with. How do we provide the right space for people to do that? Yes,
Thank
I
you.
think people need to get monkeypox if they're active, but the problem is then, where do I tell them to go to get the vaccine?
And
'Cause-
to be truthful, we don't know when you have multiple sex partners who has had sex with people of the same sex or not. We don't know who's having sex with who at all. So it may potentially be a good idea. I'd like to invite members of our audience to make comments or ask questions, not just our doctors, who I'm very proud that are with us, but any of our guests in general like to make comments, just to recognize we're not just a program for doctors and professionals. Anybody with their hands up, Dr. Walks, Dr. Neighbor-Stevens?
I do not see any hands up, Dr. Maxey.
I would like to make a comment, not at all related to what we're talking about. We have a very faithful BHT Medical Advisory Board member and weekly attendee to the Sunday sessions, who I am sad to report had a bicycle accident yesterday, sustaining neck injuries, underwent surgery this morning, and his condition is still not known. And I'm talking about Dr. Ken Steiner. And I'd like to ask, for those who are of faith, to remember him in your prayers.
Wow.
Yes, indeed. Yes, indeed. We pray blessings on Dr. Steiner. Dr.
Oh, my
Steiner.
goodness. Wow.
Or any of our advisory members want to make a comment or have a question? I see Dr. Sherrod, Dr. Rhonda Johnson, Dr. Gibson. And Dr. Pointer is not on with us today, is he?
I do not see him, Dr. Maxey.
Nor do I see Brenda Leager.
I do not see her, Dr. Maxey.
Okay. Then, okay, let's have our moderators make final comments and statements. Dr. Walks?
Dr. Maxey, I think between all of the reading that you had me do and my earlier comments, I think I'm pretty tapped out. What I will add is that one of the statements on the slides that we went through really gave me some hope, because the slide read that there are some people from that hard to convince group who have been coming over and getting vaccinated. And I think it's important for us to recognize that we need to keep that door open. It is not too late for someone who has been saying no for these last couple of years to decide that they are willing to get vaccinated. And then it's important for us to keep in mind that though the overwhelming majority of people who have died from COVID-19 are over the age of 50, there are many, 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 many people who are younger than that have also died. So it's not a severe disease only for those who are elderly and only for those who have pre-existing conditions. That's what I got.
Thank you. Dr. Barbara Davis-Stevens?
I'm going to use this opportunity to respond to a question that has been asked twice in chat, which I thought but I guess I didn't make clear. So anybody and everybody can catch RSV. The problem with RSV is the severity of the expression of the disease. And adults get it just as much and just as easily as children, but they have larger airways. So they tend to have milder pulmonary or lung findings with it. They may still have the same fever, they have the same runny nose, and they have the same cough. But that plugging and collapse of those air sacs tends not to happen to the degree in adults as it does in smaller children, because they have smaller airways. The exception being those adults who are immunocompromised or who have underlying heart or lung conditions, and they may have severe disease.
Well, thank you. In closing, I would like to offer my prayers and blessings for those of us who have undergone certain challenges, including Pastor Pointer, including Dr. Steiner and others. And we pray for their well-being and improvement rapidly, and bless everybody who's on this line and the people that we love and respect in our lives. Have a great day, everybody. Enjoy your Sunday. Have a good day.
Bye.
Good day, everyone. Bye-bye.
Thank you, Simon.